Ashray, I've got some 3 videos of how do we set up CPAP. So it's not logging on to the Mac. So what I'll do is I'll minimize my screen and show those videos and then go back into my presentation. Okay?
Yes, sir. Yes, sir. We can do that. No problem.
We are live, Ashray.
Yeah. So, good evening, dear friends and members. Welcome to yet another session. And today's is a very special session. The session will be dealt by Dr. Sudhindra sir. Sir is an anesthetic. He's practicing in UK. Sir did his MBBS from KIMS, Bangalore, MD from Manipal, and then later on went on to do Neuro Critical Care Fellowship from NIMHANS, as well as from Walton Center, Liverpool. And Sir is currently practicing at Lancashire. So, as we all know, we have been dealing with this pandemic almost. It's been 1 year. 1 year. We have been hit by the first wave, and presently we are facing the second wave. Most of us who are working in this field, like many of us are burned out looking at the number of cases and dealing with the deaths and so on. And many of you who are like yet to enter internship, all of you are worried and all of you are having this anxiety as to how this, in fact, it'll be new for you. You wouldn't have dealt with the dawning in, dawning off, and the 6 hours part. So all of you will have some amount of anxiety. So today, Sir will help us and guide us and also share his journey in this past 1 year as to how Sir has dealt with the cases himself in his unit. So can we start, Sir? And we'll be having a question and answer session as well. So you guys, at the end of the presentation, you can feel free to ask all your doubts, and Sir will be going through the questions, and Sir will be clearing the answers for the questions. So, Sir, can we start?
Thank you. Yeah, thanks, Ashray. Thanks for the kind introduction. Good evening, dear friends. My name is Sudhi, and I'm an intensive care and anesthetics consultant, as was told. So, first of all, I would just want to share my sort of support and resilience from where you are and what's happening. I mean, I've been there. We were here in the second wave a few months back, and I can share some of the sentiments what Ashray has conveyed. So what I would say is this phase shall pass too. So we just need to be together, support each other, and if there's anything, any little that I can help and I can share my experience with you all, I would be very grateful if I was making any difference. So before anything further, what I would want to say is I have a little disclaimer to make. That is that I have no conflict of interest. This presentation is based on our experience of managing COVID-19. Well, actually, it's probably COVID-21 at this point in tertiary teaching hospitals in the United Kingdom. Again, I would say it is based on our practice and what's in the current evidence, which is still evolving. So there might be a paper published later today evening, which might throw some more light into what is happening. What I would want to, however, highlight is I want to share some of the practical issues with regards to the logistics, with regards to what happens on the shop floor, what you guys would be probably dealing with. And that is something which is quite relevant. And as much as the papers would show evidence about medications and stuff, it's quite important to see that this is useful for you guys who are the frontline people dealing with things. So the slide needs to move. Yeah. So with regards to introduction, I don't think we need any more here. It's a devastating and debilitating disease as experienced probably in this century, I would say. It's wreaked a huge amount of havoc, not just among healthcare professionals, but among a lot of other fields. I mean, it's both at an individual level, both at a regional level, national level, international level. There's a huge implications, and I think we'll be bearing a lot more of the non-expressed implications in the future, which probably are not as evident. We are doing one thing at a time as it comes. So that's that. With regards to what this talk is going to be about, it's about some of the unmet needs and also some of the needs that have been met. I would say I have kind of divided this into the modification of the hospital setup, triaging of your patients as to when they come to the emergency department, them going to the ward, to the respiratory high dependency unit, or the level 2 care unit, and then if they are unwell, get escalated to the critical care. So I'm going to talk through a patient journey. I'm going to highlight some of the salient features of management, some modifications in the working plan that what we sort of got ourselves into, which works. Again, lessons learned from that as well. What happens when these patients leave the intensive care unit, and some of the issues with regards to burnout. And then I would like to put all the points together in a very brief summary. So from a modification of the hospital setup in itself, I think it needs to be happening from top down. You need to have a broader national consensus, regional, and then local. So when I say national, it's quite important that there is clear communications from the government about what should be the responsible behavior and what would be the appropriateness in terms of citizens to be dealing with. I mean, I think that's quite an important thing, clear message. And also from different specialties, again, Department of Health, from the Intensive Care Society, from the Royal College of Physicians, Royal College of Anaesthetists, we had clear communique every fortnight to say, these are the current guidelines, this is what we are doing, and this is what we need to adhere to. It's quite useful because it brings in a certain degree of solidarity and support to us, and we kind of feel reassured that the rest of the country is also doing the same as what we are doing. And you feel that, okay, my practice is in keeping with what others around are doing. It's quite important for the nursing staff as well, because from the Royal College of Nursing, there was regular updates from a health and well-being point of view, from a resilience point of view, because they're spending 6, 8, 10 hours with the patient. It's quite important for them to be also feel supported. In terms of the regional cooperation, we have Association of Northwest Intensive Care Units, where we have a network, and we work together in terms of every morning at 10 o'clock, we have a bed meeting, which kind of works as a platinum command about mutual aid. How do we project capacity? What happens with regards to patients who need to be moved from one hospital to another? So all that gets worked out in those at the regional level. And we also have a model by which in the primary care, based on the number of patients, we kind of have a trajectory of how many would get probably admitted to the hospital, and from them, how many would be perhaps heading towards intensive care. So it's a model, but again, it gives you an idea about 3 or 4 days in advance that you might be hit with a flurry of cases in the near future. So it's something to be thinking of. At the hospital level itself, there needs to be an escalation policy. By that, what I mean is you need to have a standard operating procedure as to how and when a patient who comes to the emergency department, based on certain criteria at that point, has a direction of move towards, are they going to the ward? Are they going to the high care unit for CPAP or high flows? Or are they coming to the intensive care unit that they're very sick and they need a tube straight away? So it just needs to be done as a standard procedure. The entire hospital, to some extent, needs to be divided into zones. You need to have red, amber, and green zones, and you need to have corridors made for a clear transfer of patients from the emergency department to the rest of the hospital based on these corridors. We had all the elective surgical activities stopped, except for trauma, neurosurgery, vascular, and cancer surgeries. Again, for them, we had separate super green zones created so that they were shielded from any of the red patients. The there was a huge redeployment of staff. I'll come to that more in detail, but I think that is one of the key things to reduce the risk of burnout. You need support. If you're working in the COVID ICU, in the COVID base, you need more support of people to come and help you. I think that's one of the important things, that lessons that we learned. We had hands-on teaching and also sim teaching by practice educators for donning and doffing. So it was quite a brief session, but it was quite useful to have all the staff have some kind of signing after they have done through this, so that from a governance point of view, we were aware that they were all trained. So I think that's something quite important. Now, coming to the patient pathway in itself, as I was mentioning, so you'll need to look at what direction the patient is going to go. Is it going to be benefiting to the patient, or is it going to be more towards a patient who's very frail and poorly and who wouldn't perhaps be appropriate from a escalation of care? So we looked at the clinical frailty score, and based on the clinical frailty score, they have their care plan changed. So I'm sure you're all aware of the clinical frailty score. Along with the chronic health and their acute physiological assessments, you need to know what and how frail they are. It's a scale that goes from 1 to 9. I'm sure you've all come across this. So basically what it means is 1 to 3, they're really fit and well in the range that they need to be very aggressively escalated to intensive care if they are very poorly. 4 to 6, they need to be considered as to what would be their risk benefits. And if they're very severely frail, if they are bed-bound, house-bound with very poor cardiopulmonary reserves, then you'll have to start thinking of what would be in the patient's best interest from an escalation point of view. So I think that's something that we decided, and we had a pathway. Again, these are guidelines. Clearly, this is important because as the frailty score increases, the risk of mortality also increases. So in the midst of a pandemic, you'll just have to be very pragmatic about what resource you've got and how much of it can be utilized in the most appropriate sense. So I think that's why these are important. Coming back to the patient pathway again, you have the emergency department. When the patients come in, you have a battery of investigations done. They're started on oxygen therapy, and based on how they respond to it, they would be moved towards different directions. By that, what I mean is if they are stable on 40% oxygen, saturating over 94%, their work of breathing is acceptable, they go to the ward, following which they are under the radar of the critical care outreach team. And if based on their early warning score, based on their heart rate, blood pressure, oxygen levels, temperature, and their work of breathing, they would be escalated to the appropriate level of care. And that would be either respiratory high care or to the intensive care unit. So the next level of care is the respiratory high care, in which they get facial CPAP, or if they are in type 2 respiratory failure, they go for BiPAP. But majority of the times, what we use is the CPAP. And if they are still scoring high on the respiratory high care, based on their early warning score, they would be escalated to the intensive care unit. So as I was mentioning, on the ward, it is humidified face mask, oxygen, titrated oxygen therapy through the Venturi mask. So 28%, 35%, 40%, 45%, 60%. So the key here is to have them clearly identified from their escalation point of view. So the outreach team, the hospital at night team need to be aware of them. There should be a very robust handover system so that the deteriorating patient can be identified early, and any increase in their oxygen requirements need to be rapidly escalated to the higher level of care. One of the important things, if any, to be taken home today from a message is the importance of awake proning. I think it's absolutely necessary to encourage, indulge patients into active proning. There might be a bit of probably not as much insight into the patient who's quite poorly about the importance of it, but you need to have proning champions. I mean, it doesn't take a medic. It could be anybody. Sleep on your tummy, sleep on your tummy, sleep on your tummy. That's what needs to be highlighted. It's very important. And if all these measures have not helped an admission to intensive care, then they would then come down to the intensive care unit and be put on what we use is the helmet continuous positive airway pressure. It's the CPAP hood, as we call it, as the initial mode of ventilation. And we start off with a PEEP of 10. So again, you would assess their work of breathing, their respiratory rate, and their partial pressure of oxygen to fractional inspired oxygen ratio. And based on that, you would decide as to how they're doing. The CPAP or non-invasive mode has to be used as a bridge. So at 48 to 72 hours or at 96 hours at the most, you need to have a multidisciplinary team discussion or a best interest meeting to find out if they are coping well with the CPAP, or are we flogging them very hard before we end up tubing them in an extremist situation. So it's a very significant judgment call that you have to make as to whether am I going to carry on with the CPAP and the patient's showing improvement, or is the patient gradually deteriorating to the point that I need to intervene here to put a tube down. So I think that's something important to think about. I'll just be showing some videos now. Let me just show you that. Is that seen?
Yes, sir, it's seen. I think the audio is not visible in the audio is not heard, sir, for this video.
Okay. 1 second.
Can you hear now?
Yes, sir, it's heard. It's not very clear.
I'll send it separately afterwards.
Yeah, yes.
The corrugated hose is connected to the 2-in-1 muffler adapter, which needs to be long enough to allow some ability to move, for example, moving between a bed and a chair. This is attached to one limb of a Y piece. A second short length of 22mm corrugated hose is attached to the other limb of the Y piece, and a PEEP valve is placed on the distal end of this tubing. In this demonstration, the PEEP valve is then adjusted to the desired setting. Fixed setting PEEP valves from 2.5 through to 20 centimetres of H2O are available. Variable PEEP valves are obviously a more versatile option. However, with variable PEEP valves, there is no way to determine the exact PEEP being delivered. It can only be an approximation titrated to response. The Y piece then attaches to either a sealed face mask or hood. In this case, it is a Philips Respironics Proformas mask. Flow is commenced at the desired oxygen percentage, initially at 40 litres per minute, and the mask is fitted to the patient. Titrate the flow and observe the PEEP valve, ensuring that the valve remains open through inspiration and expiration. The SiO2 and/or PEEP can then be adjusted based on clinical response. An increase in PEEP will have a resultant requirement to increase the flow to maintain the open PEEP valve through inspiration and expiration. It is important to ensure that a good seal is maintained between the mask and the patient to maintain the PEEP.
Right. So that was about. Can you hear me? Yeah.
Yes, sir, it's heard, sir.
Yeah. So I think that was the setup for the CPAP. I mean, if the audio wasn't clear, I can talk about it. Basically, it is the oxygen supply, then gets collected to the corrugated tubing, and then gets connected to the flow meter for supplying your oxygen. And following that, the tubing is connected to a Y connector, and to the other limb is a short tubing which connects to the PEEP adjustment device. And following that, you go for either the facial CPAP or to the CPAP hood. Now, with the high flows, again, it's a very similar setup where you have the oxygen source, and then you have the blender, or where you have the oxygen FiO2 to be adjusted based on your flows. You have the filter, and then you have the humidifier here, which humidifies your oxygen. And then this tubing comes, and this is the end which connects to the patient. So at rate of 40 liters per minute, you want the oxygen to be humidified, because what happens is if you don't humidify it, you will end up with a lot of risk of dry oxygen causing multiple problems. So I think it's very important to have that humidification content. As much as high flows is useful, it doesn't give you as much PEEP. So we tend to use CPAP as our first line. And when patients need a break for having some food or having their dinner, we rest them on high flow. So I think that's what has been our strategy. So as I was mentioning, awake proning is very important. So this is just some of the guidelines from Intensive Care Society website, which again demonstrates the importance of it. I think it is really helpful. I have certainly seen in my experience that proning, even with the hood or high flows, can be done when appropriate pillows are given for support. They can go into a swimmer's position with the one arm up and one arm down, or both the arms up. So it can be done. Again, no overt absolute contraindications. However, if they are quite hypoxic and if they're unwell, they need to be probably not proned and intubated straight away. So I think that's important. Equally, to help with the proning, they might be benefited by putting in a slightly reverse Trendelenburg position. And if they're very anxious and a bit distressed, a small dose of benzodiazepines or a bit of diamorphine might be useful. However, beware not to give too much, because you don't want to obstruct their breathing by giving a higher dose of benzodiazepines. So that's important. Again, you can have some timed change positions. This is just to illustrate that an individual can lie in the prone position for about half an hour to 2 hours, and then go into the right lateral position, left lateral position, or then be put up in a sort of a semi-recumbent position before going back prone. So it's something useful to have as an exercise. Now then comes the dreaded element of intubation and ventilation. So it's not a straightforward thing. I mean, it's quite a hairy situation. If you have a sick, hypoxic, unwell patient in a COVID bay, and if you have to intubate this patient in an extreme situation, it's not very easy. The patient can have a cardiac arrest. And also with all the PP and all the rest of it, you need to be quite sure that your airway management is appropriately done. So I've had situations where the patient stats has been like 50s and all that, and then we had to make sure that recruitment and all that is done before we felt that the patient got stabilized. So it is a big exercise. It's quite important to be sure that you execute it as per the plan. And for any of these things, a checklist is a good starting point. So before you go into the COVID bay, the area which is green here is where you do all these checks. Make sure that you have your team leader and allocations done for individuals for their roles. So you need an intubator, you need a runner, you need a person who's doing the drugs, who's doing the cricoid pressure, who's doing an airway assistance job. Again, I think it's easier said than done to have that many people, but at least you need to have 3 people to sort of help with what is happening. You need to have your intubation kit ready, your drugs, your vasopressors, your infusions, just to be sure that you have as many things as possible before you go into the situation where you're actually doing the procedure. So it needs a bit of a kit that is ready for this. And once you're in the COVID area, you'll have to stay focused on your intubation. And again, from an airway management, if you find that there is a tricky airway, you need to have your video laryngoscope ready just in case if you have to manage that airway. We tend to pre-oxygenate these patients with the high flows or the CPAP as it is, so keep it running till the very last minute, and only after that you would give the sedation and the paralysis and then intubate them. So post intubation, you'll have to do a recruitment maneuver. You just need to make sure that you have seen if you have the PEEP that can be either incremental or decremental depending on which way you started, and then see what is the optimal PEEP that you can set. I'll talk about that more in detail in the next couple of slides, but intubation in itself is a big deal, and it needs to be done with all those precautions. So the reason why I put this slide up is you can have different phenotypes of patients when you are at the stage where you're intubating them. You can have the L phenotype where there is reasonable compliance, early stage of the disease, not much PEEP is needed, anything not more than 10. Whereas if you are latter part of the disease, the H phenotype, which is more in behavior similar to ARDS, needing low tidal volumes, higher PEEP, and these are the patients who do very poorly as well. So the highlight is one size does not fit all. If you want to say what is the optimal ventilator settings for a COVID-19 patient, the answer is there isn't one. You need to individualize it and stand at the bedside, see what the ventilator and respiratory mechanics are, see what the compliance is, and then go by that to adjust your settings. I think that's the important thing. I'm happy to do a presentation about the ventilation itself because it's quite a lot. So in the interest of time, I would move forward. So we start off with a controlled volume mode of ventilation. And if you're really struggling as a rescue mode, we go for the airway pressure release ventilation. Now, once you have intubated the patient, you also have to consciously think about what is my next strategy. I need to be proning this patient because proning is an important thing that can be done and it can be a lifesaver. So it's very important that you have that plan in place and you have the teams who have been trained to do safe proning. Again, it's something which you as a ICU person need to see if you can delegate or decentralize it, because if you have 15, 20, 25 patients who need to be proned and deproned, it takes a lot out of your work schedule. You'll have to focus on your ventilation settings. You'll have to look at the patient's bloods and other parameters, fluid balance and all the rest of it. And you'll have to speak to the families as well. So you need to have a team that will help you with that. And also it needs to be timed in such a way that you are doing it together. So what you don't want is at 2 o'clock in the morning, bed 7 needs to be proned. At 3 o'clock in the morning, bed 11 needs to be proned. So if you have some kind of a uniformity, that will help. So we tend to prone in the late afternoon sort of evenings, so 4 o'clock, 5 o'clock, so that they get a good 16 hours. And by next morning, when the team is back again, they can be deproning these patients. So just something to think about, okay? So that's the patient pathway that I was talking about. So from the ward to the respiratory high care unit to the intensive care unit. So that's the flow chart that we've got. Again, in terms of the hemodynamic assessment and fluid responsiveness, there is a concept of optimizing pulmonary perfusion with adequate fluid reserves, which is like basically you drive the mean arterial pressure to anywhere between 70 and over to help with the ventilation perfusion mismatch and optimizing oxygenation by improving perfusion. So it is fairly reasonable in the early stages of the disease, and at the bedside you can do a passive leg raise and see if there is any change in the pulse pressure or the mean arterial pressure, which can then guide your fluid administration. So we also do routine bedside echocardiography to assess trends in velocity time integrals and the distensibility indices, because that would help in providing some fluid boluses to see if that helps. Again, one size does not fit all. So in the early stage of the disease, we would maintain them to be in a euvolemic to a slightly positive state, whereas because they're being quite dehydrated or they have diarrhea, vomiting kind of a situation. Whereas in the latter part of the disease, if they are progressed into the H phenotype stage, then you would want it to be slightly fluid restrictive. Again, acute kidney injury is quite real. It's a problem. So in these patients, it's again directly related to the virus itself causing tubular damage, as evidenced by histopathological studies. In the early stage of the disease, as I was mentioning, it's the insensible losses, reduced intake, and their diarrhea, vomiting, which would be a pre-renal source for their acute kidney injury. In the latter part of the disease, there is a combination of pre-renal and acute tubular necrosis. The management here would be, you would try to optimize their fluid balance based on their intake output chart. And if, to some extent, if you find that they are a bit fluid overloaded, and that would in some ways help in offloading their lungs by using diuretics, that could be tried. But however, if they go into an oligoanuric picture with worsening metabolic acidosis, then we need to be initiating renal replacement therapy. Again, secondary infections in these patients is quite a common thing that is noticed, especially if they are on mechanical ventilation. But as a rule, we do not start antibiotics in newly admitted patients unless they have obvious clinical pulmonary infection score greater than 6 based on their chest X-ray culture, sputum load, and their inflammatory markers. So if that is all suggestive, then we go for the trust protocol for the ventilator-associated pneumonia treatment. But otherwise, we kind of monitor their procalcitonin, and based on the procalcitonin trends, we would either initiate antibiotics or consider escalation or de-escalation of antibiotics. In the second to third week, if there is still a rise in the inflammatory markers not explained by the antimicrobial therapy, then we also need to send some fungal screening in terms of beta-D-glucans and galactomannans to see if there is an element of fungal infection that is ongoing. The problem of DVTs is quite high in these patients. Again, lots of theories behind it. It's a very prothrombotic condition. There is endothelitis. There is the neutrophil entrapment related death that happens. There is the hyperinflammation, and also a significant degree of platelet dysfunction, all of which makes blood to clot. So we have come across putting our heads together with the respiratory and the hematology team to have a dose of anticoagulation that would be accepted based on the weight of the patients. But despite this, our experience is that the risk of PE is still quite high. The problem is, if they are very sick, it's very difficult and challenging to transfer these patients to get a CTPA done. So if there isn't a contraindication for the patient's bleeding, and if their risk of hypoxia is very, very high, then we start them on the treatment dose of low molecular weight heparin. At the bedside, we are guided by the echocardiography to suggest if there is a right ventricular strain or a right heart dilatation, to suggest if there is any acute cor pulmonale features. So that's something which is done on a daily basis. So just as I was mentioning, so you confirm if there is a COVID positive patient, and then based on one of the criteria that I was mentioning, either they are on supplemental oxygen, D-dimers are elevated, worsening clinical condition, and if they are for ICU admission, then we go for what is called as a high prophylactic dose of low molecular weight heparin. And then if there is a further clinical suspicion of them having a possible PE, then we go for the treatment dose of enoxaparin. I'm happy to share these guidelines with you. I'll email them to Asha if any of you is interested. Coming to the pharmacological therapy specific to the virus, I'll kind of keep it a bit brief because this is something which is ongoing. I can probably have the whole day to discuss, debate, engage in conversations with people about what works, what doesn't work. Perhaps as I'm speaking, there might be a paper being published. So I'll say what has been our experience and what currently is the evidence that is there. So bottom line is mainstay remains steroids from what evidence we've got at this point. The three other agents, as we all are aware, are you are having antiviral agents, which at some point have an inhibition of the enzymes that relate to the virus in itself. It could be a reverse transcriptase inhibitor or another form of an inhibitor. So that is most commonly what we have is remdesivir. Immunomodulators, in particular the interleukin-6 receptor antagonist, tocilizumab is what I'm familiar with, we are familiar with. And again, next comes the antiviral antibodies, which is basically nothing but convalescent plasma. So again, dexamethasone, 28-day mortality, clear evidence to say that in patients who are intubated or needed respiratory support in terms of oxygen, there was a benefit. However, making them have steroids if there is no respiratory support can actually perhaps be a little harmful. So 14% versus 17%. So someone's at home and if they're saying, I want to have some steroids, so I think we need to think hard if they really need to be given steroids. Antiviral agents, remdesivir, as I was talking, it's shown to have some degree of shortening of the time of recovery. If started early, it has shown to have some kind of a benefit in terms of the mild to moderate kind of patients. But again, there is no mortality benefit as proven by big randomized trials to say that it is going to prevent death. Having said that, I think it's a situation where we are still learning. Recent publication has been the gyrase kinase inhibitors as by the baricitinib and remdesivir combination. Again, some promising results, but not adequately powered, I would say. So watch the space is what would be the way forward. Immunomodulators, tocilizumab, as I mentioned, it has been done. I mean, we are a part of this in the recovery and the REMAP-CAP trial, and it has shown that the interleukin-6 receptor antagonists have shown some degree of mortality benefit. Again, early days, we need to watch the space. Convalescent plasma, as evidenced by the Placid, Recovery, and quite a few of the other trials. If someone's desperately looking for plasma very late in the disease, it probably wouldn't have much benefit. But if it's a milder version of the disease, early in the disease, then it may have benefits. So from our data overall, if I were to share the Intensive Care Network Audit and Research Center data, which is the nationalized data collection for all the intensive care units in the United Kingdom. Again, total of 24,000 cases. This is a report from the 26th of March, so it's not been, we've not got another publication after that, so we're just looking at what we've got at this point. So if you look at it, we had about almost close to 60% of the patients discharged from critical care, and around 37–38% of patients died, and there's about 5% of patients who are still on ICU. Interestingly, among the 58 persons who got discharged from critical care, about 81% of the hospitals were discharged from the acute hospitals. Now, they might have got into a respite home or some kind of a rehab home or some kind of a nursing home, but if you survive intensive care, 81% of the patients leave the hospital. So interesting stats there. And if you look at the outcome based on the amount of support, if you look at the basic respiratory support, advanced respiratory support, again, wave 1 and wave 2, 80% of the patients who required basic respiratory support get discharged. So if you get milder version of the disease, you do well. If you go on to have advanced respiratory support or invasively ventilated within 24 hours, there's almost a possibility of 46% roughly 50-50. So if I were to put somebody onto a ventilator, my talk revolves around saying that you have a 50-50 chance of possibly surviving, and which is true. It's a bit scary. So 1 out of 2 patients who go on a ventilator perhaps don't make it, but that's the reality of the situation. So coming to the post-intensive care syndrome, as I was mentioning, there's a huge backlog of patients who end up having been on ICU for a period of time and then end up with significant physical, psychological, and a lot of cognitive needs. So just to highlight, it's not just the physical aspects. There is the communication, cognition, and psychosocial aspects to it. There's a huge amount of mental health issues as well, post-traumatic stress disorders. I think the fallout of this in the post-COVID era would be quite challenging, but I've kept it very minimal because I think currently with the second wave as it is, the acute aspects is what needs to be concentrated on. So that again is highlighting the needs of these patients once they leave the intensive care unit. Coming to the communication issues in itself, I think it's a big topic in itself because the amount of stress that the patient, the family, and the healthcare professionals go through with the communication is quite significant. It's a huge amount of information to be communicated to the family and to the patient. Imagine a patient who's heavily sedated, who's been woken up, and you have a man in a spacesuit standing in front of them, trying to talk to them, who's not able to hear. So it is a recipe for significant amount of delirium and cognitive impairment. So the patients themselves are hugely at risk for delirium and post-traumatic stress, and equally the family as well. So if you have to communicate to the family on a daily basis and explain to them what is happening, it's quite a challenge, to break bad news or to tell what the ground reality of the situation is. It takes a lot of effort. I think that's one of the things that doctors and nurses struggle with, because it's more than the physical elements of the work. It's the fatigue of having constantly conveying news which is not in keeping with what is happening. So if there is such high mortality, it just brings on a lot of waves and waves of these discussions. And it's not a situation where the family can come in. We have only families coming in when it's end of life care, and they have to be mask fitted, they have to be mask tested, they have to be explained all the risks that they would be having, not just for themselves, but if they are someone who are vulnerable, they can themselves get exposed to the disease. So it's not an easy thing. So it's quite a difficult situation. So these discussions are quite challenging. Coming to the redeployment of staff, I think this is very useful from a health and well-being point of view for all of those guys who are on intensive care unit at this point in time. I would like to say you need to see if there is more support and more cavalry that arrives from different parts of the hospital. I mean, they could be medical students, they could be healthcare assistants, they could be any consultants from any specialty. I mean, what we had was, we had outpatient clinics, nurses, healthcare assistants, doctors. We had orthopedics doctors coming and helping us with proning, surgeons coming and helping us with proning, anesthetists helping us with transferring patients for CT scan or bringing the patients from the emergency department. So we need to have that kind of a support because the more you feel you're by yourself and the more loner and loner you feel, the more is your risk of burning out. I think that's very important. So just coming to a day of what happens on the COVID ICU. So I go in the morning, have a very heavy breakfast, making sure that I'm fed and watered for the morning. So we go for our handover and delegate doctors appropriate for the areas based on the priorities. We then have a team huddle where the nurse in charge, the doctors, and the physiotherapists join us in identifying what needs to be done first, and who's the sickest patient and what needs to happen. And majority of the summary, opinion, and plans get done outside. By that, what I mean is you need to have focused time with individual patients in the COVID bay. So as much as possible, you need to have your bloods reviewed, your X-rays, CT scans, echoes, and all of those reviewed in the place outside your COVID bay, so that you can have a clear idea of what are you going to see in the patient. So at the bedside, it should be, you look at what ventilator settings they are, you do recruitment maneuvers, you do a focused echocardiography and lung ultrasound, and then you look at their fluid balance, you discuss with the nurse what is happening, look at the drug chart, and then you make a plan and you move to the next patient. So your time in the COVID bay has to be very specifically oriented towards what is it that you can do, because the fatigue can set in if you have not done your homework prior to getting into the COVID bay. I think that's something important that I wanted to share with the residents. And the afternoons are more about discussing with families. The most serious discussion needs to be led by the consultant. We have a family password that we have set so that once we make a call, we need to confirm that family password, and we only communicate with the next of kin, because it can happen that you can have 5 or 6 relatives ringing up and finding what is what. Maybe one extra relative we would speak to, but we would then say it needs to be communicated through the next of kin as to what is happening with the patient. So again, just to highlight from a health and well-being point of view, I lived alone here for 8 months because my wife and kids were stuck in India. I went through a phase where I had to make sure that I remained healthy, fit, and working at the best of my potential. They have joined me now, and I spend my time with my wife and kids now. What do I do to de-stress? I do a fair bit of stuff. As I said, you need to disengage yourself. Once the ICU doors close behind you, you need to try to focus your attention away from that. So I sing, I play mridangam, I run a lot. I've run a marathon recently. I run thrice a week, and basically I eat a lot as well. So you need to make sure that you have a recipe for yourself to try to remain both mentally, physically, and emotionally fit. It's very important. So the reason why I say that is there's a huge amount of cognitive load that comes through. It's not just the clinical bits, it's the pressure from what is happening, where are we going, what's the recent evidence, oh, I read this on this WhatsApp group, I read this in the newspaper, this is happening, that is happening. So there's a lot of information overload, and your brain is overworking. So you just need to have some headspace around you and make sure that you get some time for yourself. Talk to people. It need not necessarily be a doctor buddy. It could be anyone. Talk to them, engage with them for a coffee or some kind of platform where you can share what you think, and to probably let go of a few things. So I think that's very important. So as I was telling, you need to have a debrief as well if there's been a death or difficult intubation or a difficult discussion, because although you might be okay with it, the people around you, some of the nurses, some of the juniors might just want to express themselves. I think it needs to be an opportunity to encourage people to talk and to see if they want to have some opinions about some things. So it's quite important to have a debrief. So to conclude, I think it's by no means a comprehensive cover of the situation as it is, but I have tried to condense as much as possible and give you a fair idea of what we have been through. So as more and more evidence evolves, I'm sure there'll be subtle changes in the treatment modalities with things as they are. But the core principles of managing these patients on intensive care remain as it is, as what I have discussed with you. There is a need for some kind of planning up ahead, forefront, to get yourself a bit more prepared and engaged to these kind of things. So it's important. It's really important. You have some plans in place. Protocols and policies help to triage patients for admission. That's useful. It kind of helps in guiding decision making. And you need to have multidisciplinary teams in all of this, not just from a medical point of view, but also from the allied health professionals. In the ward, you would do titrated oxygen therapy and then look at your early warning score for escalation of care. If they are on CPAP or high flows, you would want to try it for 48 to 72 hours or maybe up to 96 hours. And then you need to sort of decide whether they are either improving or they're getting worse, at which point you need to think whether they need to go head for intubation and ventilation. For those on mechanical ventilation, again, lung protective ventilation and early proning is very useful. As far as the bedside echo and lung ultrasound, it's quite useful because it perhaps avoids a trip to the CT scan. I mean, if it's a desperate situation, someone's on 100% oxygen in prone position, you wouldn't want the risk to transfer this patient to the CT scanner with as they are. So bedside ultrasound is really useful. And as I was mentioning, high prophylactic dose of low molecular weight heparin in a prothrombotic state. Again, fluid balance is more about maintaining euvolemia in the early phase, and in the latter phase of the disease, it's because of the ARDS kind of a picture. You would want to be a bit more fluid restrictive. Steroids is the only class of drugs which has shown any mortality benefit. Again, as I would say, watch the space. The immunomodulators are showing some promise, and in the later part of the disease, I would say. So keep an eye out for that. Again, the socioeconomic factors are huge. Again, stress I've spoken about, and communication as much as possible in the PP and with the patient. It needs to be tried on a regular basis, and so would be the discussions with the family to ensure that they are fully aware of how sick or how unwell the patient is, and there is a risk of them deteriorating in a very short span of time. So it's quite important to keep them in the loop. So I thank you for your attention, and we have questions guaranteed in life, but I don't think we have all the answers. So if there are any questions, I would take them, and if you have any further queries, Ashray can email me about them, and I can send you our policies and guidelines if you're interested in having a look at them. Thank you.
Thank you for that wonderful and comprehensive presentation, sir. I think many of the debates we have, I think many of that is clear. And there are a few questions that we have.
Sure.
One is, Jagdish sir has asked, can you elaborate on the use of Venturi mask? And
Sure.
What should be the target saturation or the PO2 when we are going for it?
Yeah, okay. So the Venturi mask, basically what we have identified is if you put them on just a face mask oxygen with flows being, you know, some 3 liters, 5 liters, 10 liters. So we just don't get a actual gauge of what the inspired oxygen concentration is. So you kind of move towards having them on Venturi. So you can kind of get, if we do a blood gas, then you get a PO to FiO2 ratio. I mean, I'm going to talk in kilopascals here because I'm so used to it here. So PO2 less than 8 is an arbitrary cutoff. So if on 28% oxygen, if your PO2 is less than 8, so multiplied by 7.5 millimeters of mercury. So we can multiply it. But if the PO2 is less than 8, that would then trigger us to see if we need to increase the oxygen. But likewise, the oxygen saturation that we go is 94%. So if they are less than 94 saturating consistently on what fractional inspired oxygen they are on, we then increase it to the next level of Venturi. But having said that, if beyond 40%, if their work of breathing is high and if they are not responding to proning, and if they have other risks in terms of their AKI getting worsening, or if they are hypotensive, that would then trigger automatic escalation to critical care. Is that okay? Does that answer your question?
Yes. Another question was, many times we see, because there is a huge shortage of
Huge shortage of,
ICU facility or oxygen availability in the beds. Shortage of beds in the hospitals.
Yeah.
So many of the time we start patients and they require anticoagulants. Someone has asked, what is the role of newer oral anticoagulant, NOACs for anticoagulation? Which NOAC to use and what should be the dose for prophylaxis? Or is there any role for prophylactic NOACs?
I would be a bit careful with the use of NOACs. I mean, if you're talking about a patient who is on very high amounts of oxygen and we are struggling to find a bed for him on enhanced care unit, then I would say perhaps you would go with apixaban as a starting point. But again, I would be a bit wary to use NOACs because with heparin, there is a reasonable amount of chances that you could have some kind of reversal. But having said that, I've certainly not had to use it. But if you were to start any kind of a NOAC, I would say perhaps apixaban would be the reasonable starting point. I mean, I've not come across, I mean, although on the Intensive Care Society, Indian Society of Critical Care Medicine, I'm on the panel of the international doctors who are helping out with consults. I've had consults from far-flung areas where they have started warfarin as well as an anticoagulant in patients who are really hypoxic. So it's difficult for me to sort of justify the use of these agents beyond the settings of where would be enhanced or high-level care. But if you're saying that they would imminently then end up being on intensive care, then perhaps apixaban would be my first line, I would say.
Yes. One question is, if people have already been tested positive, is there any chance for reinfection after 3 months?
Yeah, if they have tested positive, it depends on what the symptoms are. I mean, if they have tested RT-PCR positive and if you have been through the disease as such, are you talking about someone who's discharged from the intensive care unit, or is it someone who's been asymptomatic and then have tested positive? Is that what you're asking? In what context?
The questionnaire is not very clear on that.
I can probably tell you about
both.
Yeah. So if you have a patient, like we've had patients who've been on the unit who've been tracheostomized and who have been tested on a weekly, I mean, we have a guidance of testing, especially with now our elective green pathway being started. So every patient gets tested thrice a week. So if they continue to test positive, and if they have an aerosol generating with regards to either they are tracheoventilated with a cuff down weaning, then we keep them in a separate side room. But the rule is beyond 14 days of them, if they don't have symptoms, if they don't have a persistent high temperature, if they don't have a productive cough, and if there's no identifiable reason to believe that there is another alternative source of infection, then it's very unlikely that they would be transmitting the disease as such. But having said that, each hospital, each country has different isolation guidelines. What would be reassuring to say is that beyond 14 days, if they have no symptoms, very, very unlikely that they would be a transmitter, but they would be viral shedders, because if you go by the test that you're doing, RT-PCR, the RNA is going to remain in the body. It's not going to go away anywhere. So it's not a question of whether you detecting it is an indication that they are going to be infective. Are you with me? Are you understanding what I'm trying to say?
Yes, sir.
Okay. But if it's someone who's had one vaccine dose and then has got infected, then that perhaps is an active infected stage, because probably they've not got themselves adequate immunity or adequate antibodies, and they would be continuing to have a bout of serious infection. So at which point they'll probably have to have the period of isolation as it would be.
Few more, just to extend that question further.
Sure.
Many of us are getting vaccinated. So how long would it be significant to consider a reinfection because of either it is vaccine related infection versus a new infection? So how do we really decide based on that, sir?
So if you have been vaccinated, again, this is all what I'm reading and what I'm quoting from experience from people. Okay. So if you have been vaccinated and if you have given yourself at least 3 weeks after the first dose, then you have a fair amount of antibodies to say you've got about, depending on which evidence you look at, around 60 to 65% of immunity kind of a thing. But if you've had 2 vaccines and if you have then had 3 weeks time after that, then you have at least over 95% immunity. So basically, what I would say is if you have had your second dose and if you have crossed the 3 weeks after your second dose, then your chances of getting the infection, you might, again, based on what we are looking at, variants and all that, but the chances of you getting severe infection are very, very less. So you would get a mild infection. So you might get a bit of a malaise, body ache. You might get a bit of temperature, a bit of a runny nose. But beyond that, you wouldn't, in the current context of what we are seeing, end up needing intensive care or augmented oxygen therapy.
Sir, a lot of the students who are attending today are like who have just passed out and going for internship. So
Okay.
this is something really new to them. Like many of us have already done the COVID duties, so we might have been accustomed to it, but many are still apprehensive about it. Like they have that their own anxiety issues. They are scared to go into such a situation. So any piece of advice to them?
Yeah, I mean, we've had medical students who have come in to help us with proning patients, with helping the nurses in giving them breaks, being runners outside the COVID bay. So I think first and foremost, my personal view is, if not during a pandemic, when is it that we are going to be learning about this? So, okay. So if we have people shielded away, saying that, okay, this is a bit risky, this is what is a bit of a difficult proposition, then it becomes a bit difficult from a learning point of view. But equally, you need to have your accurate, appropriate, satisfactory, reasonably high standards of training for your donning and doffing. That is one of the most important things I would say. You should be all definitely mask fitted, depending on what kind of a mask. Are you an N95 person? Are you a respirator person? Are you there are different types of masks that are used. So you need to be sure that you have your full PPE on for the appropriate procedures that would be the case. So donning and doffing is very useful, and I think it would be also useful if you run through, as senior doctors, you guys, Ashray and team, some scenarios or sim-based learning about what will happen if there is a patient showing red flags of desaturation. What do you do if there's a patient having episode of needing intubation ventilation, or how do you escalate care? How would you run a resuscitation scenario if a COVID patient arrests? So these are things which we run as routine drills. We have mock drills, and we also have simulation related training for these, where we prepare the medical students, the interns, the foundation doctors to kind of engage in this. So I think all I would say is we need to reassure them, and you need to know that you have enough support and you have help to go to when you actually need that. So I think that's the most important message I would put across.
Dr. Sudhindra?
Yeah.
What's your opinion on the use of ivermectin in the clinical cases?
Yeah, I mean, I've read a fair bit about it, but in our clinical practice in the UK, we haven't used ivermectin. Again, 12 milligrams is the dose which is used for 5 days. I mean, as an anti-parasitic agent for an immunomodulation, there are 3 not so good powered trials which have suggested that there is a suppression of the immune response, not as much if there is an overt cytokine storm. So again, I have been asked this question on the ISCCM platform as well. So I would say perhaps it's not useful. So is for doxycycline as well. So is for azithromycin, unless there is a need for an antibacterial agent as a cover for a community acquired pneumonia or a hospital acquired pneumonia, then I would go for antimicrobials. But as far as the agents which have no proven efficacy from an evidence-based practice, I would say no about it. So I am not sure is the answer, but certainly we haven't used it, and many of my colleagues have also mentioned that they haven't had any experience with it.
Thank you very much. And another question, could dexamethasone be replaced by prednisolone or methylprednisolone?
Oh yeah. Yeah, I think as long as a steroid of an appropriate dose is in place, it would be fine. We use 6 milligrams dexamethasone once a day for 10 days with a PPI cover. And again, it can be increased if they still are needing oxygen therapy. We also have situation where we have methylpred as a pulse dose for 3 days, 1 gram. If we are seeing that there is on the CT scan a certain inflammatory process that is still going on, to see if we can help with arresting that. So yes, any substitute for dex is fine. I have seen that there is a certain degree of tapering of dose that gets done, but I'm not quite sure in an acute setting any tapering is needed. If you keep the dose as it is, as long as it's not an industrial dose, you keep it in the sensible doses of what it would be, along with some kind of PPI cover, that would be good enough.
Thank you. Thank you very much.
Thank you. Thank you.
Very, very nice lecture. Got glued into this. I think it was wonderful.
Oh, thank you. Thank you.
Sir, what about the use of HRCT? Like many of them have started to use off late HRCT for the diagnosis, so that if Corad's 4 comes, even then they can be taken up for the treatment. So there's widespread use of HRCT now.
Yeah, I think
can we highlight role of HRCT in the present trending conditions?
So I mean, I think the HRCT would kind of give you an indication of what the severity of the disease would be, and to kind of prioritize your management from where you would go. It also gives you, I mean, certainly I find that there is an element of what the coexisting disease is. Someone's got already an element of emphysema, bronchiectasis, a certain degree of lung disease that is existent, along with what you're seeing from ground glass changes with the CORAD score being quite high, then that would make you more worried about the trajectory of this patient's clinical condition. So I would still say that it is an adjunct. It is not something certainly which drives my clinical management. I think the clinical management is purely dependent on how they respond to your treatment strategies. By that, what I mean is you need to intervene quite early. If your HRCT is showing there is a quite a significant disease in itself, you'll have to have the escalation done quite sooner rather than later. So the important thing to think about is if the interval CT scans done are showing a significant disease progression, it kind of gives you an idea of how the patient from an L phenotype has perhaps progressed into the H phenotype, and has then also, if added on with a pulmonary angiography on that, it will show if there is an element of subsegmental or a segmental PE that is also contributing to your hypoxia. So any interval scans would add value, but the scan in itself, initially to guide your management, is not something which would be a very optimal strategy. Does that make sense?
Will it help in aiding the diagnosis of COVID, sir? Can we take it that way? Like many reports are coming RT-PCR negative with Corat score 4 and they go on for the treatment.
I would say CT precedes. I mean, when you say RT-PCR negative, I think the sensitivity of this test needs to be understood in the context of the condition. So CT is definitely more sensitive. So you would have perhaps more of a movement of this patient towards the disease within the next few days than with the RT-PCR being negative. So it might be that they're still in a prodromal condition and they're not having enough viral load when the swabs get done. So I would say, yes, it aids in your diagnosis. And as I said, it would clearly help in the management. And as much as the radiologists now have a definite pattern recognition of what they are seeing, with all due respect to them, there is a fairly good consistency in the reporting and the patient then going on to have overt symptoms that get presented with. So I think, yes, it does have its value in identifying the patients early in terms of their clinical deterioration, if that would be. But if the RT-PCR is negative and the CT shows that they have features suggestive of COVID, then I would definitely believe it. I mean, that's one of the main reasons why we created what is called as amber beds. So although their swabs were negative, their CT scans came back as positive, in which case we kept them in an amber bay and then continued to repeat RT-PCR. And if they got unwell to the point that they needed a tube, then we sent the sputum PCR, which then eventually would come positive. So I wouldn't disregard a CT report which suggests COVID. But having said that, I would be guided by the clinical picture as far as their management goes.
I have one more question, if time permits. Is it okay?
Sure. Yeah.
From your experience, what is the total duration of illness generally, and which is considered as the bad days in terms of critically?
In terms of the, you mean to say the duration of illness of the based on the phenotypes, or are you in terms of the disease in general?
In terms of the disease, as you
experience
in your hospitals.
Yeah, sure. I think in terms of the disease in itself, what I would say is it's quite variable based on the individuals. I mean, I certainly have seen patients who have rallied for a really long time, have got on to get tracheostomized, have then gone for a prolonged period of weaning from the ventilator, and then have eventually got decannulated, went to the respiratory ward, to the rehab unit, and then have managed to go home. But equally, I have seen a deterioration within 6 hours of a patient who was profoundly hypoxic, then got referred to ECMO, and despite that didn't do well. So it's a very variable response. But if someone has presented quite early in their disease, if they've been very sick enough quite early in their disease, and we have them intervened at a very early stage, then perhaps they might have some degree of improvement down the course. But having said that, early intervention with a breathing tube in itself has got its own limitations because of the huge amount of inflammatory mediators that are released, along with a breathing tube and positive pressure ventilation can itself cause a significant amount of volume trauma and barotrauma. So not everything that we do on intensive care for these patients at the high end of the spectrum is beneficial. So the answer to your question is each individual has a variable response, but if it is male, if they are obese, if they have chronic health conditions, and if they present being very, very hypoxic at their presentation, they do very poorly. So, but if they have a milder version of the disease, have been in the hospital for 24, 48 hours, then deteriorate further, come down to us, go on to the CPAP hood or the mask, and then 3-7 days down the line, they are gradually weaned off the oxygen, they do well. So the more severe they present with to us, the more higher their mortality risk, despite very early interventions.
And sir, most of, like, only a small chunk of these people come into ICU. So most of them are well managing at home. And on daily basis, all of us tend to get calls telling what to do, what is the home treatment can we take, and when we should go to hospital, or what tests we need to get done, any routine blood investigation that needs to be done for mild illness. So any advice that we can share on the milder part of the illness, sir? And when they need to be referred to hospital?
Sure. I think this is a question which perhaps is more common than what we see at the deep end of the spectrum. So for the asymptomatic patients who are sitting at home, I would say adequate rest, adequate hydration, light exercise. Measure your saturation, but not frequently to the point that a drop in 1% makes you so stressed and agitated that you start, having almost a stress response kind of a thing. So it is quite important, and it's not to disregard the situation, but equally, I would say a period of patience in asymptomatic patients who are otherwise able to talk in full sentences, have no increased respiratory effort. Their work of breathing is okay if they can sort of, stand up, sit down, do their activities of daily living, can have a little bit of walk in the room where they are, or engage in some kind of a reading. It is fine as long as they take paracetamol 1 gram 4 times a day. That is the only thing that they need to do. However, if it gets to a point where their saturation is dipping, and according to the Indian guidelines, it is 93% or less. So if it is dipping to less than that consistently, and they are subjectively feeling that they are out of breath, their respiratory rate is increasing, their breathlessness is out of proportion to the activities that they are normally able to do, in that case is when they need to seek medical advice. Because I have come across patients who in the early viral replication phase at home are started on steroids. And what then happens is you are actually causing more harm than benefit by having the steroids started quite early in the disease process. So I think at that point is when you would want to have a medical consultation. Again, I've had a lot of reports to be looked at in terms of the ferritin levels, LDH, troponin, D-dimers, and also to see if that adds anything important to the overall management. So by that, what I would say is that as a baseline, they're good. They would be elevated, but if they are very disproportionately elevated and in keeping with the clinical picture of someone being very unwell or they have deteriorated, that's when it needs to be escalated for admission to the hospital. So if you are mildly symptomatic, then seek medical advice. Then by all means, I think they need to be started on some steroids, but I am not convinced about any kind of doxycycline or aspirin or azithromycin or ivermectin according to our practice.
Can I ask one more question?
Yeah, sure.
Yeah. I being an animal practitioner, COVID series of coronaviruses in animals invades other systems apart from respiratory system. Primarily invades the gastrointestinal system in dogs, pigs, etc. So similarly, in human beings, does this COVID virus invade other systems apart from respiratory system?
Yeah, it does. Actually, there is the pathophysiology is pretty much evident in every organ system in the body. I mean, the brain gets affected. There's a definite COVID encephalopathy that is quite obvious. Again, the obtunded nature of an individual is not perhaps also related to hypoxia, but there is a encephalopathy that happens, a viral encephalopathy. In terms of the myocardium, they can have myocarditis. One of the early presentations in some of the young patients is viral myocarditis. We've had one case where a patient had myocarditis, which presented with pericardial effusion. So they can also have cardiomyopathy, again, later in the disease. The vascular system, as I was mentioning, the endothelium and a lot of the blood vessels in the body are affected. The marrow in itself is affected. There's lymphopenia and also a fair degree of platelet production suppression that happens as well. In terms of the gastrointestinal system, although there isn't direct affiliation, there is a certain degree of diarrhea, vomiting, which can then lead on to them having kidney damage as a result of intravascular dehydration, and also tubular necrosis because the virus directly attacks the kidneys as well. So the liver in itself can also be affected. Having said that, the liver functions derangement is more related to the medication profile of what we would be giving to these patients. So yes, all in all, I think the virus doesn't spare any organ system. It's a very devastating virus.
Thank you. Thank you very much.
Sir, can you please talk a bit more about post-COVID sequelae, sir? Many of them are coming up with fibrosis.
Yeah.
Other this thing. So, bit on post-COVID sequelae, if you can tell us, sir.
Sure. So, I think post-COVID is depends on, again, there's a lot of, if you look at the respiratory system in itself, there's a lot that is happening in these patients as a result of COVID, if they survive the COVID condition. I mean, there is a huge inflammatory process, partly as a iatrogenic response by the body in terms of the cytokine storm or the production of quite a significant doses of inflammatory mediators. And also, if we have subjected them to prolonged periods of CPAP, the CPAP in itself with the positive pressure can produce a fair degree of shearing stress and volute trauma, barrett trauma, which in itself can bring about a certain degree of pulmonary parenchymal changes. So the fibrosis or the significant changes in the gas exchange that happens is there to stay. There has been some consideration of having these patients on a slightly prolonged periods of steroids from a fibrosis point of view. Again, there's a lot of work being done about it. I'm sure it would leave a certain degree of interstitial disease as such along with the fibrosis. So the gas exchange would be affected, the mechanics would be affected. So you would need a period of prolonged pulmonary rehabilitation before considering any move back to home and everything. So in terms of the acute cor pulmonale itself, in terms of the heart-lung interactions, there would be a certain degree of right heart strain. There is a trial which is looking at use of phosphodiesterase inhibitors to see if that would in some ways help with this. Again, it's on a trial and error basis at this point in time. But we certainly don't actively use unless they have been 3 months down the line, because with the disease in itself, we don't know how much of a reversibility and how much of irreversibility and what is the rehab potential in these individuals. Some of them who are young and fit are very motivated. They get onto the rehab program very well, whereas some individuals are quite not on the same scale as the other. So it's something which needs to be individualized, but yes, the problem of fibrosis and the sequelae is very real. hope that answers the question. Yeah.
Yes, yes. Uh, so then one of the doubts were on happy hypoxia, sir. Yeah, so they'll just ask what about this happy hypoxia?
Yeah, happy hypoxia, as you would say, I mean, I'm sure you've probably all come across this. This is in patients who are fit and well, who can tolerate a certain degree of hypoxia without having their cognitive function being significantly affected. So I have seen patients in their 40s who are having a hood on, texting away on the phone, or doing something on Twitter or Instagram or something, but their saturation is sitting at 82, 84%. They're not even aware of it. So I think the concept is that these patients can tolerate hypoxia for a very long period of time. If you look at the oxygen dissociation curve, and once a threshold is reached, they fall off their perch. So it's quite important to guide your therapy based on what your partial pressure of oxygen is at that point in time, rather than purely demonstrated by your saturation. So if your blood partial pressure of oxygen is significantly low for the amount of oxygen that you're providing, then I would say I would be very worried about this individual and perhaps preempt a higher level of care. Having said that, when they are happy hypoxics, if it is something where them proning or side lying would help in some ways, you will have to be aware of it. So the difficult question is, at what point do you have to intubate these patients? Are the happy hypoxics just carrying along as they are without showing signs, and at 2 o'clock in the morning, they just have a significant drop in their oxygen levels and then are in a peri-arrest situation? Or is it that we keep an eye on them, and then they start improving? So that is a question which is very, very difficult to answer. I mean, and this is across experts all across the world. I mean, I have had a patient who at 11 o'clock was fine, and 2 hours later, we finished the grand rounds and came back, and he was so hypoxic that he needed a tube straight away. So it's very difficult about what the end result and end point of a happy hypoxic is. But all I would say is have your blood partial pressure measured, and if it's very dangerously low, then you need to have a multidisciplinary team discussion as to whether there is anything that can be reversed with the current treatment strategy, or we need to escalate it to a tube. Hope that answers, Ashay.
Yes, sir. Yes, sir. Yes, sir. Jagdish, sir, any other questions that we need to put across, sir?
If there aren't any other questions, then I thank you all for your attention. Yeah.
Yes, I think so. That's all, sir. So thank you so much, sir. This was
Hope
really
it was useful, and if you have any feedback, please let me know. And if you have any further questions, you can email me and let me know if you want to have any of our policies or any guidelines.
Yes, sir. Yes, sir. Very enlightening session, sir. It has helped many of us actually. And we would also like to thank Dr. Jagdish, sir, who actually came up with this idea. So it was his idea that whoever is going to work or whoever is working at the COVID wards, they need to have a thorough idea and knowledge as to what they're doing. And would also like to thank Sudhindra, sir, for doing the same. So also the participants for coming for the session and listening to sir. So I think so we can wind up the session. So thank you, sir. Thanks a lot.
Thanks a lot.
And thank you, participants.
Bye. Thank you. Bye.